I'm David Brown, Director of the Virginia Department of Health Professions. Welcome to Virginia's core competency modules for pain management and addiction. These competencies were developed by work groups convened by Virginia's Secretary of Health. Over 24 experts in pain management and addiction compiled the essential competencies that Virginia's health professional students must acquire, not just our future physicians, nurses, dentists, and pharmacists, but the wide range of professionals who work with these types of patients. These modules, made possible by a Department of Behavioral Health and Developmental Services grant, present key parts of the competencies for use not only by our schools, but by practitioners already in the field. Thank you for your careful attention to this important information.
Hello, I'm Dr. Robert Trestman, Chair of Psychiatry at the Virginia Tech Carilion School of Medicine. What I'd like to discuss with you is some of the challenges we each face as we work to help support our patients who are dealing with pain. So as we go through this, we will be working in this first module over a series of different steps to address different areas and aspects of some of the basic notions of pain, how to assess it, and how to have a conversation with our patients. In the first topic of Module 1, let's begin to talk about what the science is behind our understanding of pain. The basic definition is that pain is an unpleasant sensory and emotional experience associated with real or potential tissue damage, or described in terms of that kind of damage as the person experiences it. It's important to recognize that pain is always going to be subjective. Each individual learns the application of the word pain through experiences related to injury and our experiences related to that injury early in life. Pain is that experience we associate with real or potential damage to ourselves. It's unquestionably a sensation in a part or parts of our body, but it's also always unpleasant, and therefore there's always going to be an emotional component to pain. Experiences which resemble pain in some ways but are not really unpleasant, for example, a sensation of pricking, should not be called pain. And if we distinguish that, it will make our jobs much easier as we're working with our patients. There are a range of unpleasant abnormal experiences that we usually label dysesthesias. They may also be pain, but are not necessarily so, because subjectively, they may not have the usual sensory qualities of pain. Many people can report pain in the absence of tissue damage or any likely pathophysiological cause. Usually this happens because of psychological reasons. If they regard their experience as pain, and if they report it in the same way as pain that's caused by tissue damage, we should accept it as pain. This definition usually avoids tying pain to the stimulus and allows us to engage in a critical conversation with our patients. Over the years, there have been many different ways of treating pain, of addressing it and understanding it. Many of them we now see as either dangerous or useless, and this is an underlying theme of much of what we're doing. We've now come in many ways to understand some of the more neurobiological bases for pain. And what I'd like to do over the next few moments is just step through some of the biology of pain. Nociception is the sensory recognition of a painful stimulus. It begins at the terminal end of pain-sensitive neurons, which project from the spinal cord out to the periphery. In this context, Typically, either these A delta or C fibers have a wide range of receptors on their terminals. These receptors are responsible for translating potentially damaging, threatening events into signals that travel up the nervous system to reach consciousness or a reflex to generate an appropriate behavioral response, ultimately to protect ourselves. From these nerve endings, the signal goes to the spinal cord for processing. The cell bodies of peripheral nerves located in the dorsal root ganglia are responsible for conduction of that signal up towards the central nervous system. Pain processing in the hindbrain, particularly the rostroventral medulla, evolved as a defensive stimulus. Pain involves deep brain centers in the medulla, and it is at the very basis of the origins of human sensory processing. From there, the signals go up to the midbrain for further processing, particularly in the ventral tegmental area, or the VTA. It's located near the red nucleus, just above the level of the pons. The ventral tegmental area has been related to salient sensory and emotional coding. And in turn, those are related to reward-based learning and ultimately to what we are grappling with in part because of pain these days, the issues of addiction. Progressing up the central nervous system, we arrive at the periaqueductal gray. This is situated around the cerebral aqueduct, deep in the tegmentum of the midbrain. And the periaqueductal gray is a well-known target for the modulation of pain signals. From there, we find a high density of opioid receptors in the habenula, and it connects to the limbic forebrain with both hindbrain pain modulation centers as well. In this position, it's not surprising, therefore, that the habenula has a role in both chronic pain and in the process of addiction. Similarly, the thalamus is an important target of ascending spinal activity, and it has a principal role in pain perception and in pain pathology. Within the limbic system is the amygdala. The amygdala is a bilateral cluster of cells in the temporal poles known to be involved in emotional processing and in memory processing. It can be subdivided into several nuclei, including the central nucleus, involved in both sensory and pain processing. One of the real challenges we face in the neurobiology of pain is that there is no single cortical structure or pathway responsible for all aspects of the pain experience. It is diffuse and complicated. So as we think of it, there is certainly a subjective pain experience that arises both from the nociceptive pattern of signaling as well as the cognitive regulation of those signals. So there's an intrinsic mechanical aspect to the nociception, but there are cognitive and emotional components as well. This is frequently described as the nociception perception suffering model, suffering which links pain to the emotional experience of pain. When we talk about this, we also must think about the matrices or the connectivity in the process of cortical pain processing. There is a primary matrix which we can refer to, in which information about where the stimulus comes from, the proprioceptive components of where in space in our body is the signal coming from. There's also a secondary matrix which focuses attention, or doesn't focus attention, on the pain. And these operate in parallel. There's a third level, and that matrix integrates these first two and generates the final consequential behavioral response to the pain. We frequently think about a biopsychosocial model of illness, which incorporates both biology, the psychological experience, and the social context. There's a similar model that is of value to consider when we speak about pain as well. And so from the central aspect in the blue concentric circles of first nociception, or the perception of pain at the level of the sensory neurons, there is then the experience, typically acutely, of pain. But then there's the overlay of the emotional experience of pain, which we can frequently describe effectively as suffering. And then the consequential expression of that. What is the pain behavior? What does the individual do, and what's the consequence of the pain? Whether it's a reflexive removal of the hand from a surface that's too hot, or months later, how we behave in response to chronic pain. So as we've been describing, there is a modulation to the process of pain, going from the bottom and the original trauma and the recognition by the body through sensory neurons that activates the peripheral nervous system through the transmission of those signals. Again, activation of the central nervous system at the level of the spinal cord. There's then the input into the central nervous system, the transmission of the pain signals to these matrices in the brain, a recognition of pain. And then it's modulated into how we act, how we perceive, and how we deal with that perception of pain. This creates, in many ways, a cycle where there initially will be the pain. And let's start at the bottom. And there can be nervous system changes in response to an injury, and that can induce a range of nervous system changes, alterations in neurotransmitter type and balance, synaptic action and activity, and even potential cell death. Subsequently, in response to that pain, our muscles may tense and guard if there are specific areas in a limb or in the central body that leads to chronic pain, and our muscles will adapt. But that guarding leads to consequences of disturbed posture and activity, range of motion, and when that occurs, there can be a loss of elasticity, loss of flexibility, which can lead to all sorts of, in the extreme case, contractures. Along with that, there can subsequently be muscle atrophy because of unused muscles as a consequence to the chronic pain. That's all the physical and pathophysiologic consequences in the body. There's also the consequence that results to it. When we experience pain, we can be afraid that it will get worse, or even if it leaves us temporarily, there's the fear and anxiety that it will return. So there are all of these emotional complications to the initial experience. That can in turn lead to a significant emotional consequence that is expressed as depression, and the full range of expression that can lead to a diagnosable major depression with consequent changes in regulation of neurotransmitter function and synaptic up and down regulation. And certainly something we hear frequently from patients who present with pain that has lasted significant times is significantly disturbed sleep. And in this context, there can be a vicious feed-forward loop that can consistently expand and worsen as it feeds on itself. So this leads frequently to this behavioral maladaptation, the pain can lead to physical deconditioning as well as mental deconditioning, going from the first stage of an initial psychological distress through more development or exacerbation of some of the psychological problems, a sense of helplessness, a loss of sense of control, the anxiety associated with this, as well as anger, frustration that can come from the fear, and can lead in turn to a whole range of subsequent disorders and reactions that may lead to substance abuse, a sense of anger, distrust, and entitlement that we sometimes see in patients whose pain has not responded to treatment. Finally, there can be a sick role in the final stage, which leads to a lack of willingness, energy, or even a sense of conceptualizing a recovery from the chronic condition that our patient experiences. And so pain changes over time. And what we've been discussing is the sequence. Again, in terms of definitions so that we have a common language, there's the initial pain, there's the initial stimulus. And acute pain is pain that we describe that has been present for less than 3 months. As a subset of acute pain, there is subacute pain. That is pain that has been present for at least 6 weeks, but less than 3 months. Chronic pain is pain that persists beyond what would typically be considered a normal healing time, typically present for over 3 months. Chronic disabling pain is pain that has persisted for more than 3 months and interferes with activities in daily life. This brings us to the end of the first topic. As we begin the discussion in the second topic, which will be the challenge of discussing pain with our patients, and particularly we will focus on the assessment of pain. Thank you.